vents, because right from there, we go up into our arterial side, into our arterial cannula, and into the patient. So that gives us a couple assurances. One, if there's any bubble that's here, it's going to clamp off and we're not going to be able to give it to the patient. Or at least hopefully we're not going to give it to the patient. When this goes off, this instantaneously closes. So if there is anything, we should be able to stop it before it gets to the patient.
And then, like, when the centrifugal thing's spinning, so you're kind of shunting everywhere else, right? So there's flow still in the circuit, right?
Correct.
Yeah, okay. Then you're just shunting it everywhere else besides to the patient.
Right.
Okay.
And that's pretty much the entire pump in a nutshell. We can go over, if anybody has any questions about any type of emergencies or anything that you've seen in the past, we can discuess that now if anybody has any questions.
When you're going down on your flows now, you're opening up the bridge, correct?
Mm-hmm.
And that's just, I mean, sludge white, just less, because less pressure is going through the circuit. Is that why you're opening it up?
So remember when I said earlier, when we had 400 flow, it takes a full minute for that blood to get through the circuit. So when we're weaning down, so when we're weaning down, here's our bridge right here.
Right.
So when we're weaning down to come off bypass, let's say we want to come down to 200 or 150, we'll pop this open. And of course, again, last time I did this, it didn't come down, but now that we have some back pressure with our pseudo patient, it should. So right now we have a flow of 550. And if I open this bridge, it should actually go down quite a bit more. Or quite up more. So I open the bridge, and now we got 800 flow going back there. However, we have 800 back here, and if we move it up above the bridge, we have 500. So you can see, since I opened the bridge up, we increased the flow back here, but we've actually lowered the flow going to the patient. So as we're weaning down on our flow, so we wanted to have 200. We have our bridge open. We'll say 300, so I don't have to go in there. We have our bridge open so that even though we only have 300 going to the patient,
I'm sorry, I can't. Okay, thanks. Okay, bye-bye.
$500 going to the circuit, so we're getting a full 200 mLs more protection of the circuit. There's the circuit we want to keep moving around.
Going away from the base, right? Because you don't want it to the infant, but you got to keep the circuit from clotting.
Exactly, because we may have to go back up on flow. If the patient doesn't wean, we may have to keep this circuit for quite a bit longer. So that's why we'll move the flow probe, because we actually want to see what's going on with the patient. If we open this up, we're not getting what's going on with the patient, we're getting what's going on with the circuit. There are times when the centrifugal pump does fail, and that's why we have our little hand crank. Not everybody that's done hand cranking in the past with the roller pump, you get sweaty and it takes a lot of effort to get things right. This is very, very simple. It's very easy to use and requires not much effort at all.
You did not find a different place to do it except in front of the patient?
Yeah.
Sorry.
So to use the hand crank, pop it out of there, put it into here, and then it's ready to go. And we'll move it to where we have, obviously this wouldn't be there. This would be to the baby, so we'd have free room. And then that's it. You just crank it. I mean, I'm doing this with one finger. You could do this for hours. It doesn't tire you out like the old one used to.
But aren't you supposed to simulate the heart rate?
You are. And so that's another reason why we'll always look for the RPMs. This actually has an indicator on the top that shows the RPMs that you're giving to the patient as well. So we'll try and keep it around there. And then we'll still have the flow reading on here too, so we can match the flow as well. So right now, just by doing this, I'm getting a flow of about 550, 600. So it's very easy to use. It's I kind of equate it to CPR. If you're not familiar with it the first time you do it, the first time you do CPR, you're pumping away like crazy. It's the same thing with this. If you can really get but then you're flowing 6 liters to a 3 kilo baby. But by having the little RPM indicator on top, we can actually keep that.
But it's clockwise you're doing it.
Yes. Yeah, it won't let you do it the other way. So.
Didn't we do counterclockwise on the bottom, on our roll call?
You're right. Yes, it was.
Did we? Yeah. I only did it once.
But it only lets you go one way. If you do it this way, there's no resistance. If you do it this
So
way,
then
you
you
get
know you're going the wrong way.
exactly. Now the ECMO specialist should be the one doing this, but in case they have to run and do something else, they may
That's what happened.
they may
Lost my ECMO specialist.
they may announce somebody to go ahead and.
Something went wrong with the
yeah.
pump and I was
Exactly.
cranking.
But that's it. If anybody else wants to, if anybody else wants to spin this, just to see
Dee
how
knows
easy it
this,
is.
but I don't know if
versus,
you remember watching the videotape on Katrina, but the one kid that they had, they were hand cranking on an ECMO.
Were they? Yeah.
And it was the old guy.
So you can see how easy that was versus this old hand crank where you constantly using a lot of force to do it.
What do you think about the...
So that's essentially it. Does anybody have any questions? Or does anybody want to see anything?
What are some of the common questions you get when you're
This is not a very high ventilated setting.
Yeah,
surprised because it's given with the VO2 of 45,
No,
VO2 in the 50s for me does not bother me actually.
Most of the questions,
but I want to see how the blood
I have to say,
on
lately
the
have been
conventional
about the
ventilation
tag because
before,
we're using that
you
so
can
much.
maintain
And it's unfortunate we didn't have the room because I could have showed you in my
conventional
little
ventilator, even if
presentation
you have
about
to
the
go up
tag and the
on the
different
tidal volume.
aspects about it. But again, I'm going to get you that PowerPoint. You can hand it out to people. It's pretty self-explanatory, the slides. It goes over, one slide is about ACTs, one slide is about tag, and then there's another slide that kind of has the different,
You can make
the normal tag
on the
versus
conventional,
a bunch of different things as well.
Okay.
I would love to see
Thank you.
Oh yeah, I'm gonna
I'm gonna
email it to
have,
you.
he's gonna send it to me and I'm gonna put it on,
That's fine. She do her CPT, suction, and then 30 minutes later, gas.
Julia.
No, it's
Julia,
again.
tell me.
Are there any other questions?
No, thanks. I'm good.
All right, great. Thanks for
Thank you.
Yes.